I'm humbled. I'm very honored to be presenting my lecture in your webinar series. The title I've given for my lecture today is An Exit from Lockdown in Orthodontics. Good morning, good afternoon, good evening, everyone. All of you watching me live from all over the globe. I am Dr. Pushkar Manandhar, working as an assistant professor in Department of Orthodontics and Dentofacial Orthopaedics, People's Dental College and Hospital, Kathmandu, Nepal. Nepal. I'm from Nepal, and Nepal is situated, actually, it is land lockdown country between big countries like China and India in the Asia. The peculiar thing about Nepal, the unique thing about Nepal is its flag. Except for Nepal, everyone in the world has its flag in a rectangular or a square shape, but we have it in a two triangles. And this triangle represents the Himalayas mountains of Nepal. Out of 10 highest mountains of the world, Nepal has 8 of them. And considering the first Mount Everest being in Nepal. The capital of Nepal is Kathmandu. It's a place where I was born, brought up, and still working in Kathmandu. Kathmandu is a beautiful valley. I request everyone to once visit Nepal, Kathmandu, once in your lifetime because it's a majestic Himalayas and all the scenarios. So let's begin with my lecture. First, let me introduce myself. I did my Bachelor's of Dental Surgery from University College of Medical Sciences, College of Dental Surgery, which is situated in Bhairahawa, Nepal. In 2002, I graduated from in 2007. Then I came back to Kathmandu. I worked as a clinical coordinator in dental department of Kathmandu Model Hospital in Kathmandu. And after a few years, I then went back to Manila, Philippines for my Master's of Science in Dentistry, major in Orthodontics degree from the University of the East in Manila in 2009. Then I graduated in 2012. Currently, I'm working as an assistant professor in one of the oldest dental colleges. In fact, the first dental college of Nepal, People's Dental College and Hospital in the Department of Orthodontics and Dentofacial Orthopaedics, Kathmandu, Nepal. And I also do my private practice as a consultant orthodontics in Samas Dental Hospital, New Baneshwar, Kathmandu, Nepal. So before I begin, I would like to begin my lecture with remembering my principal when I was doing my BDS, Professor Dr. J.N. Sinha, Dr. Jadunath Sinha. He was a periodontist. He used to tell me, dentistry is more delicate and sensitive than microvascular surgery and neurosurgery. He debated that whatever they do, microvascular surgeons and neurosurgeons, they can at least see what they are doing. They're cutting the nerves, so they're suturing the small things. With the aid of their gadgets like microscope and all those things, they are at least seeing what they are doing. But we dentists, some of the procedures are such that we never see what we are doing. You agree with me? Let's talk about RCT. We are doing RCTs and we never see the root canals. We clean them up, we shape them up, but still we don't see. Even we fill them up, the root canals, but we never see the root canals. Even the accessory canals, we clean them up, we fill them up, but we never see the root canals and even the accessory canals. Similarly, prosthodontists, they deliver dentures. To get a good denture, we need to have a good borderline, PPS. For that, we need to take impression. And we are doing that without seeing any borders, right? And for the oral surgeon, they take out tooths, impacted tooth, in fact, but they never see the tooth. They never see the root unless they're out of the socket. But they do so gracefully that without damaging any surrounding structures. Even the periodontist, they do the root planings, but they never see the root unless it is out of the socket. But when they're still in the socket with the good periodontium, we never see the root, but they still clean the roots. Root planing is done with the sensation, with the imagination. They clean the roots. And now for we orthodontists, we move the teeth through the bone without seeing the half of the tooth. That is the root. It is still embedded in the bone, but we still manage to move the teeth to bring it to its correct position. And worst of it comes when the teeth is impacted or fully buried inside the bone. We have to take that impacted tooth out and get it into the right position. We need to have an exit plan to get that lockdown tooth onto its position. I hope everyone agrees with that. If we don't have a proper exit plan, what happens? Like this. Last year, we were locked down in our houses for like 60 days because of this ongoing coronavirus. And after 60 days, the infectious rate uh, decreased to 5%. So the government say, okay, you can come out. But there was no such as exit plan for that. And everyone came up to the road and this happened. There was chaos in the streets and there was a big traffic in the bus and everyone suffered. And this time, we again had the second wave 2 months ago, and we were in lockdown till last week. And this week, government had a proper exit plan for that one. They slowly opened up lockdown. Like first, they opened up the shops, the essential goods shops. Now they are opening the streets for like odd and even basis. And still, the infection rate is below 5%. So I mean to say, we have to have a perfect, proper exit plan and a perfect execution to get a good result. And same implies in our orthodontics. So today I'll be talking about, I'll be telling you 5 stories which we did a proper exit plan and a perfect execution of it. So we'll start with our first story, lockdown number 1, and I call this hide and seek. So this patient, 21 years male, came to us complaining of malaligned teeth. So you can see in the picture, there is a crowding, there's a high canine, and the second picture, if you could see or not, there is a second molar playing hide and seek with us. It is the second molar lockdown. Second molar is locked behind the first molar. On the OPZ, we can clearly see the 7, that is the second molar, is tilted mesially and locked behind the first molar. So it is unable to erupt by itself. And this is causing the patient a little discomfort. So to plan this thing out, to get this locked second molar on the occlusion, we had an exit plan in our whiteboard. So this is the schematic diagram of the situation that was in the real person. And what we did, we bonded, we'll be bonding and banding the teeth, and we'll run a 010 night-eye wire, but not in a regular fashion. We'll just little twist in this one. We'll run the wire in this manner. We'll insert the wire of the second molar from the distal side, going down the buccal tube. So what happens if we run the wire like this? There will be 2 forces acting on second molar. One in a distal force, which will unlock the second molar from the first molar. Then another force which will be acting upward direction in rotation like this, which will place this teeth into proper position. That was our exit plan from this lockdown. So what we did, we bonded the arch, we placed a buccal tube in 3/7 as banding was not possible. Then we ran a 010 night-eye wire, and we placed a lingual holding arch for a better anchorage. This is a side view there. You can see the 010 wire is run from downwards to backward and then inserted into the buccal tube from the distally. Then wire end was secured with a composite stop. And then 012, 014 where wires were changed on subsequent visits. Now let's see what happened. After 4 months, the second molar was almost in the occlusion. After 5th month, it was like this. And on debonding, it was properly leveled and lined. And this is the IOPA we took after the debonding. So the locked second molar was unlocked. Now, next one, lockdown number 2. And I call this double trouble. In lockdown number 2, a patient came with this intraoral pictures, a 13-year-old male complaining of unerupted tooth. You can see many teeth are not there in the oral cavity. And it was a mixed dentition case, and there were teeth present were on the first quadrant 1, 2, E, and 6, and the second quadrant 1, 2, E, and 6, and third quadrant 1, 2, 5, and 6, on the fourth quadrant 1, 2, 3, 4, and 6. So basically, patient was complaining that there was not teeth coming out in the oral cavity for a long time, especially on the third quadrant. So we thought maybe there's something wrong. So we took an OPG, and to our surprise, there was our double trouble. Our third quadrant had 2 impacted teeth, canine and premolar, that too one on the other. The premolar was lying on the canine. So to take this out, we need to have a proper exit plan. It was canine premolar lockdown. So for the exit plan, we again went back to the whiteboard. We simulated the case in this whiteboard. So we thought we will be doing this case in 2 phases. First, we will be exposing the first premolar, and we'll be applying the force in this direction so that it will rotate in this direction and go back to its position. And when it is leveled and well aligned, we will be doing our second exposure to the canine, and we'll be pulling the canine in this direction and then this direction so that it will come into its original position. So it seems so easy here, but when we went to the case, we had to have some anchorage plan. We need to pull the teeth when we put the lingual bud. So we thought we'll make an appliance like this, which is a modified lingual holding arch, where you can see lingual holding arch. We bend a wire like this, outward bend in the space, so that this will be acting as a anchorage where we will be pulling the teeth, which is impacted here from here to this wire. And for the uppers, we made a space maintainer Nance holding arch with a thick anterior resin, so that will also correct the deep bite as well as class 2 malocclusion. Then we did the premolar exposure. We bonded the lingual button and the premolar, tied it with the ligature wire to the bendings in the modified lingual holding arch. And in 3 months, the premolar was in the occlusion, you can see, but still not level and aligned. So we kept on changing the wire till we got this in the 5th month. The premolar was well aligned and positioned. Now we need, according to our plan, we will be pulling the canine into the occlusion, but there was less space, so we placed a open coil between the laterals and the first premolars. Then we did the on the 7th month we did the second exposure. Sorry, I don't have the pictures for that one. 10th month, the canine is almost showing. We can see the lingual button over here, and then we had our lockdown, so I don't have the pictures after this. Maybe I'll be presenting the later other pictures. Maybe next time I'll be presenting. Because of the lockdown, I couldn't meet the patient right. So finally, we got our premolar unlocked and canine in process. Now, next story is a lockdown number 3, and I call this the Wanderer. Or number 3, this was a 19 years old female which was referred from Department of Prosthodontics complaining of missing teeth. Then we saw inside his mouth, her mouth, and the intraoral pictures were like this. And we saw that there was a canine lockdown. It was because of the buccally placed canine, space distal to the 1 tooth, but the other teeth, you can see there's a good intercuspacity. Class 1 molars on both sides and class 1 canine on the left side. More intraoral pictures reveal that the lock canine between the premolars. It was a case of a transposition. So there was an overjet of 2 mm, upper midline was on, and no buccal corridor on the right side because of the ectopic eruption of the canine. Then we took the OPG, so see if what is the condition of root there. But it was not visible properly in the OPG, so we suggested for a CBCT. And on CBCT, it was clearly seen that canine was situated between the 2 premolars, and it was the case of a complete transposition. So now we were here back again into plan and exit. So we thought we'll make an appliance like this, which is a modified NAND palette. Here you can see the NAND paletter with the resin stop here, but over here you can see a small bending is done like this over here, just palatal to the first premolar. And we inserted this into the patient mount. Here you can see we bonded a lingual button on the palatal side of the first premolar and placed an elastic chain from here to the hook to retract this premolar more palatally so that we can make a way for this wanderer to move to its own house here in the space of canine. So after 4 months, we can see the premolar has moved more palatally. Then we bonded the upper arch and placed a 1622 SS wire with this kind of formation, so that we have an insert over here, but we can push this as well as pulling the first premolar to make a way for the canine, our wanderer. Then on 8th month, we bonded the canine also. We bonded the canine and placed another arch wire with the same 1622 SS with a bending in this manner in a curve at this place and push the canine with the help of an open curl so that the teeth will move in this wire. On the 11th month, as you can see, the canine is rotated more mesopalatally so that this will go inside this space. And on 16th month, we were able to place the canine in its own position, surpass the canine roots of the premolar. Then we placed a ligature wire from the bracket to the downward in the wires to pull this downwards. And we thought we were done at this time until the 19th month, the patient showed with this occlusion. Can you see there? We observed a dehiscence. The root was completely out of the bone. I was so afraid. We used different thing. We used the chalking spring also, but we were not able to get the teeth inside the tooth. So what we did, I went back to my bending schools. I bent 2 vertical loops, one mesial, one distal to the canine, and the wire segment between these loops, I gave a torque. Yeah, of course, palatal root torque to get the teeth inside the bone. And then on the 23rd month, you can see the root is going in. You can compare 19th and 23rd month. You can see how the teeth is moving in. And finally, on the 24th month, the tooth has gone in, and we have unlocked the locked canine. Happy ending. Now, let's move on to our next lockdown, as lockdown number 4. And I call this the third class. Okay, this patient was 13 years male, was complaining of a forwardly placed lower jaw. And he has a previous orthodontic treatment history. He went to some dentist before 1 year. When we met, before 1 year, he has gone to his previous dentist to correct his lower jaw forwardly placed. And according to him, he was using face masks for 1 year now, but still there was no change at least. So he came to us to get this fixed. And then he had a concave profile. And intraoral pictures revealed that the maxilla was knocked down. There was a negative overset, class 3 canine and class 3 molars, retrocline lower incisors, posterior cross bites, and ectopic canine. And moreover, we also had lateral incisor lockdown. The incisor was standing behind the centrals and the canines. We also had the screwed upper arch, negative overset of -4 mm, black collider, buccal collider, nasal level angle 85 degree, and mental level sulcus angle 157 degree. We took the OPZ, everything was fine with the OPZ, and we studied the lateral ceph. And after doing the cephalogram metry, we got SNA with a 77 degree, which is maxilla, SNB as 85, prognatic, somewhat prognatic mandible, and total A and B came out to be -8. U1 NA was 26, IMPA was 81, and moreover, SMI, skeletal maturity index, showed stage 4. That means 10 to 25% of growth is remaining, and 10 to 25 is a very small amount. So we thought we'll take an hand-wrist radiograph. And on the hand-wrist radiograph, we saw that fusion of epiphysis and diaphysis in the radius was already seen, and fusion of epiphysis and diaphysis in the middle phalanx of thumb finger was seen. That means this is stage 11. And what does a stage 11 signifies? It signifies that 97.2% of maxillary growth is completed. It's completed, almost 100%. We only had 2.8% of maxillary growth remaining. And it's very, very, very negligible, especially in this kind of cases. So growth modification was a big no in this case. So we talked with the patient, and then we said we cannot do anything right now. And he said, so what is the option? And we gave him an option of orthodontic surgery, but that too after 4 to 5 years, at least 4 to 5 years, because the maturation has to be stopped. So patient went back and came back after 3 to 4 days, and he said, "Doc, we don't want to go for surgery. What can be done?" And we said, yes, all the diagnosis procedure, it says we cannot do the rod modification. It's like a big okay for orthodontic surgery. We cannot do anything. But what he said inspired me. He said, at least you can try, because anyhow, I'll be going for orthodontic surgery after 4 to 5 years. So maybe at least you can do something, at least you can try with a rod modification or whatever. If it comes out good, we all are happy. If it not, also I'll be happy, and maybe I'll go for surgery after 4 to 5 years. And this inspired us a lot. So we thought we'll give it a try. We'll try face mask. So we placed expansion appliance like this with the jack screw in the middle, and we had hooks on the distal to the canines for the face masks. But What we did a little different in this case was we used alt-ramic protocol. Instead of just expanding the upper arch with the jack screw, what we did, we checked a literature in Ajodo, and according to that, we had a turn of 4 turns in a day, which is 1 millimeter per day, for 7 days expansion and 7 day compression. So what we are doing is we're doing expansion continuous for 7 days, and we're closing them again for next 7. And this vicious cycle goes on for 7 weeks. So basically we were expanding, compression, expansion, compression. So this occurred for 7 weeks. So what did this do was it separated the whole maxilla from its sutures. So it was a loosen up. So on the 7th week, we placed the face masks on the patient. We used Petit type of patient, and we strongly instructed the patient for a minimal of 14 hours of the wear. So in the 9th month, we bonded the lower arch. On 10th month, you can see on this month, the face mask was discontinued. Upper arch was bonded, but still there was negative over Z. On 22nd month, you can see we have finally jumped the bite, and we unlocked the maxilla from the lockdown. Now what remained was our second lockdown in the same case, our lateral incisor. For that, we extracted the first premolar to get the canine into class 1 occlusion, like this. Then you can see we took a step. You can see how the maxilla has come forwarded and the mandible has rotated clockwise. So we did the superimposition. You can clearly see how the maxilla has come forwarded. The superimposition, we measured. This was our last measurement, P measurement. And now SNA jumped to 82 from 77. That is 5-degree change in the maxilla. That too, when the diagnosis says more growth modification is not possible. We had SNB decreased to 83. This was because the mandible rotated downward, and A and B came out to be -1 from -8. U1 from 26 to 29. IMPA from 81 to 90. Over Z from -1 to 1. That's where we jumped the bite. It was 8 mm of overbite. Now it is only 1 mm. And above all this, without any significant evidence, we tried this. All diagnostic procedures said no for this procedure, but still we tried, and we got total maxilla protection of 6 mm. And that was what makes us happy, what makes patient happy. So on the 20th month, we placed retraction of O12 was done with O12 night-eye wire overlay with the posterior bite plate given. And if you could see the exit plan for lockdown from 0 month to 7 month, just focus on the maxilla, 0 to 7, 7 to 16, and 16 to 20. Can you see the difference there? From 0 to 20, when all the diagnostic procedures said it is a no for growth modification. When the other dentist used the same face mask for 1 year and he couldn't protect the maxilla, and that we did. And that makes the patient happy and we also happy. Now, coming up to the last story, lockdown number 5. And I call this the prison break. Okay, this patient, 13 years male, complaining of malaligned teeth, was referred to us from the Department of Periodontics. These were the intraoral pictures, and it showed the mandible was locked down. Unerupted upper canines were there. Class 2 molars, retained upper left deciduous canine, retrocline upper center incisors, procline laterals. So there was something fishy about this. There was retrocline centrals, but procline laterals. And there was a spess distal to the upper right laterals, deep bite, and unesthetic smile. Then we took the OPZ, and the OPZ was like this. Can you see that canine there up in the root of centrals and the laterals? So it is a canine lockdown. So we thought we'll pull that canine to the occlusion. Then again, we thought, let's have a literature check. What does the literature say? One of the literature I found, it says that the difficulty index of the impacted canine is depends upon four factors. The one is angulation of canine to the midline, vertical distance from the occlusal plane, mesodistal positioning of canine tip, and finally, the position of canine root apex antero-posterior. So these were the four factors given in this article, which determines the difficulty of index. Either the canine has a good prognosis if we want to pull it down, or a poor prognosis if we want to extract it. So let's talk about this factor one by one and then correlate this with this case. The first one, the midline. So if the canine's angulation with the midline comes out to be 0 to 15 degree, it has a good prognosis. We can get it into the occlusion. But if it has 16 to 30 degree, okay, average prognosis. But if it is more than 30 or 31, it will be having a poor prognosis. So when we see to our case, it is more than 30 degree. So this is clearly indicated of extraction. We don't want to extract, don't want to protect this canine into the position, the oral cavity. So this is only one. We have three more. Let's go on to another. Occlusal plane, the angulation. If it is the below the level of CESA, it has a good prognosis. But if it is above the CESA, but less than the halfway of the root, it has the average prognosis. And if it's more than halfway up to the root, but less than full root length, it has average minus prognosis. But it is above the full length of the root, it has poor prognosis. So what do we have? We have average minus prognosis. Means it is more than the halfway of the root, but less than the full length of the root. So maybe we have an average prognosis. So that was poor prognosis. Now it is average minus prognosis. Maybe we'll be having good prognosis next one. So next one, here you can see if there is the canine has no horizontal overlap with the adjacent to, that is the laterals, and it has a good prognosis. If it has a less than half the root width, it has an average prognosis. If it's more than half, less than the whole root width, it has average minus prognosis. But it has, if it is completely overlapping the root width or more, it has the poor prognosis. And in our case, we have the poor prognosis. It's going beyond the central incisor, not only in the laterals, going beyond the somebody is crossing the midline also. So it is like poor plus prognosis. The last one. So last one says, if the position is above the region of the canine position, the the root apex is above the region of the canine position, it has a good prognosis. If it is above the upper first premolar region, it has average prognosis. And if it is above the second premolar region, it has the poor prognosis. And our last hope, it has the poor prognosis. So according to this, we don't want to retract the canine to the position. We need to have this extracted. But we're not giving up so simply. So we thought maybe we can find something in civicity. So we prescribed a civicity. And according to civicity, if you see here, the cut section, this is the tip of the canine. It was behind the central. The tip is behind the centrals, if you could see. Now, if you go on, and see somewhere over here, the root is lying buccally to the laterals. So basically, canine is trapped between the two incisors. It is in behind the bar. It is in prison. And we thought this is very challenging. We need to have a strong exit plan to get this lockdown canine out of it. We want to have a prison break in this case. So we were planning an exit plan in our whiteboard. So this is the situation. On your left is a view from the labial. You can see the root of the central is on the buccal side of the crown of the canine, whereas the root of the lateral is behind the canine. On the right, you can see the view from the palate. Maybe you have a nice imagination of this situation now. So what we thought, to get this out, maybe we can do this. Maybe we can extrude the centrals, so it will be free from the roots of the centrals. Then we can pull this down and down this proper position. Wow, this looks so simple in the whiteboard. We thought we will try this. So we explained everything to the patient, the risks of having failure of this thing, but the patient was more enthusiastic, more excited than us. He said, let's do it. And his parents also were like, okay, let's go for it. So we started. So first, before we starting, we need to have an appliance inserted in his mouth that can provide self-limiting anchorage for the extrusion of control with control force, that can provide the anchorage for retraction of the canines, and correct the class 2 as well as an myofunctional appliance. So first we chose the myofunctional appliance to be twin block. Then we place some, we modify the twin block, which will be providing the self-limiting anchorage for the extrusion, and also will be providing anchorage for the retraction of the canine. So this was the twin block we made. You can see there, this wire will be acting anchorage to extrude the centrals, and these hooks here and here will be used to retract the canine. Then we bonded a Beck's bracket with a slot facing gingivally on 2-1. Then we attach an elastic chain from the bracket to the extension for the extrusion. So after 9 weeks, what we saw, we were able to achieve a 2 mm of extrusion. And when we took the IUPA, can you see the clearance between the root of the centrals and the canine? So we were through the first part. So we broke the first bar of the prison. Now we need to get the canine out from there for the prison break. After 2 months, we exposed the canines, both the canines. We attach the lingual button to both of the canines and attach a keychain from there. And you can see the right canine is almost in the oral cavity now. But you can also see the prominent bulge over the tutu root area. That means the canine is coming out. And we took an IOP just to confirm, yes, it's coming. And after 15 months, we can see the canine is out in the occlusion. We stop the twin block also. And finally, we got the unlocked canine lockdown. Now you can see the profile of the picture, patient also, the effect the twin block gave. Can you see the mandible coming forward? Now on 22nd month, open coil spring was placed between 2.2 and 2.4. 0.1 to 90 overlay with 16 into 22 SS base wire was placed. Then an elastic thread from 2-3 bracket to the base wire was placed, and class 2 elastic was also used. Now, can you see the exit sequence there? When we saw this OPG first, we were like, oh no, we're going to extract that. But we did have a good and smooth prison break. So the formula for a good orthodontic says that always start any case with the end in the mind. You have to be very, very, very imaginative in this kind of case. You need to know what is going. You need to know you need to have a good knowledge of all the anatomical structures, what is going on. You need to have your imagination when you're pulling out things. Okay, this is going there. There is this route. We need to surpass this route. So always start with the end in the mind and a proper treatment plan, a proper exit plan should be made. Not only planning should be done, it should be a smooth and perfect education. So this is the end. Thank you, everyone. This is our People's Dental Orthodontic team, our colleagues and our PG students. There are two colleagues missing in this picture. So thank you. Thank you, everyone, for having me here and listening